Now, a trauma center, as most people know, is more than just an ER. Something happens, you go in, you get stitched up, you get sent home. Trauma centers around the country go a little bit beyond that. They want to make sure that whatever brought you there does not have the same potential to bring you back again. So, hit by a car, fell off a ladder, gunshot, knife wound, whatever it is, we want to make sure that the door at the trauma center is not a revolving door. You come in, you get stitched up, sent back out, and you're coming back again. Now, we all understand the current dynamics, right? Things happen in our neighborhoods. Some things can be prevented. Some things may not be as easy to prevent. But the point is, we want all of us to be as healthy as possible. Live as long a life as possible. And that's why we fought so hard to make sure the trauma center came back to this part of town. And so this is an opportunity for us to begin to really realize what that means. And so we want to gain the wisdom from you based on your experiences of what it is that we need to make sure is included in that trauma center in addition to the surgeons, the nurses, etc. Does it sound okay?
Okay.
That sounds all right so far? So we're not going to keep you here a long time. I've already gone a little bit over what I was supposed to. I'm really supposed to just make sure that this beautiful woman comes up and shares what we're going to do this evening and move us through the program. So Veronica really needs no introduction. If you have been on the planet for the past couple of years, you know the name and the face well. If you Google her name, I know, right? You Google her name, it's like your screen just goes crazy with images of Veronica and Trauma Center Now and all that stuff. She is one of the young black leaders that's heating up the streets, right? While we recognize the need for a trauma center to come back to this part of town, we also recognize the need for greater police accountability, right? And Veronica has been one of the leading voices in that battle, putting her body on the line to make sure that justice came to our community. So with that, I'm going to turn it over to Veronica Morris-Moore.
Thank you, Jawanza, and everybody that is here that has struggled with us for all the years. So I just want to very quickly talk about our agenda, and then I'm going to talk a little bit about the power that we have. So in a little bit, we're going to have a panel. It's going to have folks who are here to talk about the type of services that Jawanza was talking about that help people when they have to go to a trauma center and not have to go back. After that, we'll have breakouts in which everyone in this room will have an opportunity to use their voice in a breakout group that's facilitated by someone from the Trauma Center Coalition, from one organization from the Trauma Center Coalition, and there'll be different questions that you can answer and that you can also ask. And it's very important in these breakout groups to really think about what type of trauma center, if you had to go to this trauma center that will be at the University of Chicago, what do you want to, what is the experience you want to have? What is the experience you want your family to have? What is it that you want to come from it? After that, we'll do report backs. I'll give a call to action, and then we're going to have to get up out of here. So before we do all of that, though, I very quickly want to talk about our power. It's very important that we start this conversation off with our power, because our power is what has us in this room. As we all know, the Trauma Center campaign started in 2010, and it was started by a youth organization that was supported by Southside Together Organizing for Power. Young people suffering poverty, racism, sexism, all type of things came together to fight for something. To fight not just for something for themselves, but for the community, right? So it's something about that that was able to shift a dynamic between an institution that has a history of not valuing the lives of the people who are directly outside of its doors, to answering to those very people whose lives that they did not value. And the way that we leveraged that power, the way that we garnered that power, was by working in community with each other, by supporting each other, by challenging each other, and also by challenging the institutions that are inside of our neighborhoods that have a responsibility to treat our people like they people who go to those institutions, who work for these institutions, are treated. We use that power forcefully. We use what we have. We use direct action because direct action allows for us to go directly to the source and say that you cannot exist while we're dying. You have a responsibility to address that.
That's right.
And we were consistent for 5 years. And it wasn't because of anything sexy. It was because of people who loved each other and who wanted to see each other live and thrive and survive, and who were tired of dying. That type of power is the type of power that most institutions, most people who hold a traditional form of power do not want us to tap into. Because when we tap into that power, anything is possible. Like a trauma center at the University of Chicago. And so I really want us to sit with that as we listen to the type of services, to the type of opportunity that this trauma center could give, not just for those who are in need of those medical services, but for those who live down the block, for those who live down the street, and for people who aren't here yet, who are going to need those services in that trauma center just as much as those who are here and those who aren't anymore. So that's my piece. And with all of that being said, I would like to invite the representatives from Ceasefire, Healing Her People, and the National Nurses United to come up so that we can begin to have a conversation about the type of services the University of Chicago Trauma Center can provide.
The approval of the trauma center is huge. You know, we stand with the community in this fight, and the community stands with the nurses in making patient care safer and more accessible. So I just want to say thank you to everyone for their effort. I've been a nurse for 5 years, and I take care of mainly cardiac patients from all over the world, but primarily our patients are from our community. I love being a nurse because I get to care for these patients during the most difficult moments in their lives. Whether they've just had a heart attack or been told they only have months to live, I get to know these patients and their families and help them through this difficult time. I don't just go to their room and give them medication and walk out. I get to have real conversations with the patients and their families while taking care of them. I'm one of the first people to hear that they can't afford their medications or that their wife just passed away days before. I'm the one that they come to with all their questions. When a patient is sick in the hospital, that's not the only thing that's wrong with them at that time. They're worrying about their insurance, their bills, work, their children. This only makes it more difficult for the patient to really focus on their healing. And then I not only end up helping them with that issue that they're there for, but helping them find solutions to their problems throughout their whole life. I love helping them not just recover physically, but really help them heal, and not just their body, but their mind and their soul. Because this is the kind of care that our patients deserve. Opening the trauma center is just not enough. All patients, not just trauma patients, deserve to have high quality care. No patient should have a nurse that is too tired because they didn't have a break in their 12-hour shift, or because they're too busy because they have more patients than they should. All patients deserve high quality care. As a nurse, it's my duty to be the patient's advocate, and I'm not just an advocate while they're in the hospital. I'm an advocate beyond the bedside. I fight for everyone in our community to have the quality of health care and quality of life that everyone deserves.
And when you guys talk, just please remember to project over this fan. Let's keep us off from melting. So, yeah, go ahead.
Hi everyone, can you guys hear me? Should I stand up too? Okay. Stand up too. Hi, my name is Sheila Regan. I work for an organization called Ceasefire. Has anybody heard of Ceasefire? Okay, great. So for those of you who haven't, Ceasefire is a public health organization that was founded by an epidemiologist, and we're housed in the School of Public Health at UIC. It's also a community-based organization. We do violence prevention. We do it here in Chicago and in cities across the country and across the world. For the last 10 years, we've been doing violence prevention work in trauma centers. So we've been working at Christ Medical Center in Oak Lawn, serving the south suburbs, southwest side, south side of Chicago, southeast side, northwest Indiana. Since 2010, we've been at Northwestern Memorial Hospital, which catches some of the patients that would potentially be going to U of C as of right now. And we've been at John H. Stroger Hospital since 2011 and just started at Mount Sinai Hospital, which puts us in most of the major trauma centers in the city of Chicago, serving patients injured by violence. I'm trying to think what else I can say about the organization for now. I mean, that's basically where we're at with it. We try to prevent violence on the front end, so mediating conflicts before it actually gets to gunplay or an actual altercation. But in the event that that is not possible, we go to the hospital and try to prevent a retaliation and try to help, hopefully work with the hospital staff, the clinical staff, and any social service support staff to try to get a better outcome for that patient. So we're working with the patient and with the families. And of course with the community. My background, I came from Mount Sinai Hospital. I worked in the social work department there back in 05, 07, and then since then I've been working with Ceasefire. I was working at Mount Sinai in the social work department referring patients to Ceasefire because there was not really any other organization that was specially designed to work with folks who were violently injured like that. So I ended up working for Ceasefire for the last 10 years, building out their hospital program. And that's sort of where we're at in Chicago. We have been in conversation with U of C. We're hopeful that U of C will adopt a Ceasefire approach as well to help serve their patients. And that's what I have right now.
Good afternoon, I'm Carol Reese. I work at John H. Stroger Jr. Hospital of Cook County in the Department of Trauma. I've been there for about 10 years and I have multiple roles there. I'm technically speaking the violence prevention coordinator for our department. I'm also an ordained Episcopal priest, so I function on our team clinically as the chaplain in the Department of Trauma, and I'm also a licensed clinical social worker, so I'm in charge of developing the mental health responses primarily on the inpatient side. So for a number of years, our folks at Stroger have been concerned about providing outpatient services to the young people and young adults who come in through our department. We're lucky to have had a long working relationship with Ceasefire, and then for the last 3 years we've been in a partnership with Comer Hospital and Drexel University in Philadelphia to implement a program called Healing Hurt People. Healing Hurt People is a hospital-based violence intervention program. I mean, if you think about it, it's obviously not a primary prevention program, because when we encounter patients, they've already been violently injured in some way. So our goals really are to reduce retaliation, reduce the likelihood that someone would be re-injured, and then we're also working with the young people that we see in our hospital to reduce the rates of encounters with the criminal justice system. So for right now, in the partnership with Comer, is a pediatric level 1 trauma center. Stroger has both adult and pediatric level 1 trauma center patients come through. We're working primarily with the pediatric patients, which is kids under the age of 19. And so we see families and children as young as 3 or 4 years old who've been violently injured on up through kids who are 18 years old. The program begins in the hospital with our initial encounters with the patients in both hospitals. We get referrals from physicians, nurses, social workers in the department. Can't hear me? All right. She's going like this. Well, we begin with kids when they first come into the hospital. We get referrals from social workers, from physicians, nurses, who inform us that a young person has been violently injured. And then our team of professionals, either social workers, chaplains, or both, engage the family right away to do the crisis intervention piece and begin to make sure that they get the medical care that they need. And then from that point, we try to enroll them in the outpatient services, which is an intensive case management program where we intend to engage these kids from 6 to 12 months at a minimum to work on goals like getting them back and re-enrolled in school, dealing with their probation officers if they're involved in the criminal justice system, helping them to find jobs, those sorts of things. And it's also important, a part of this program, to get folks hooked up with mental health services. Probably about 40 to 50% of our kids and their families suffer from PTSD symptoms because of their violent exposure in the community. So it's important to us to create avenues for them to access mental health services through resources in the community, resources at the hospital, and also with their the intensive case managers who are assigned to them. So that's the Healing Hurt People program. I think it's an important part of the work that we do at Stroger and at Comer, and hopefully as the Level 1 Trauma Center comes to being, we'll also be able to serve adult patients in both hospitals.
So we're going to ask some questions, and I'm going to ask the first question. I want to give folks time to think about the type of questions that they want to ask these people who represent services that could actually do what we talked about, right? Helping folks not have to go to a trauma center, providing services beyond just reactionary care but proactive care, and actually thinking about in what real way can these services benefit you, your family, and other members in our community. And so my first question that I want to ask each of you and give you an opportunity to answer is, how do you see your particular service specifically benefiting the Woodlawn community at the University of Chicago Level 1 Trauma Center? And you can answer that in any direction, and please remember to project.
Well, I mean, I'll start. I mean, we're already with the Healing Hurt People program, but we're already in the community here. We see patients at Comer, and the families that are referred to Comer or come to Comer referred to us by the hospital staff. Some of the patients that come to Cook County Hospital also are from this part of the city. A couple of other things that we're doing in Woodlawn is that we have a support group as part of our programming, and we're currently running a group for adolescent boys at Woodlawn Adult Health Center. So we anticipate that that will continue there. And then we've also worked in collaboration with Wheaton College to develop a mental health clinic that's at the First Presbyterian Church that's also here in Woodlawn. So we provide free mental health services to patients and families who are referred to us. So we anticipate, you know, being able to expand and grow the commitment that we've already made to the patients who are served by the university system and by Cook County Hospital in this neighborhood.
Thank you.
Excuse me.
Yeah.
So, I heard this council using the word referral. So, are you saying that the only way they can get these services, they have to be referred to you from a doctor?
No, so because it's a hospital-based program, the young people who we serve, the point of entry for our services is because they're violently injured at the hospital. So that's the way that we're working right now. So we're in the hospitals. Like I have a staff of like 6 people, social workers and chaplains who are at county hospital, and they identify patients as they come through. So we don't need a referral from a doctor, but it is a hospital-based program, so that's the way to access these services at this point.
So the answer will be, you have to be referred by a doctor.
Well, the answer is that you have to be violently injured and in one of these hospitals.
At that particular hospital.
Right now, yeah.
Are you on call in the emergency room?
I am. Yes.
So there are people in your capacity there at the moment that someone comes to the emergency room.
At Stroger Hospital, yes. Yeah.
Anyone else wants to answer the question?
Yeah, I can answer that. And you actually made me think of something I didn't mention when we were talking before. Our program is 24/7, so we are live response 24/7 to all of our hospital partners. And like Carol said, our program is actually also serving Woodlawn. Any patients that live in or were shot in Woodlawn, shot or stabbed or jumped on in Woodlawn that go to any of the trauma centers. So that would be Northwestern, Stroger, Sinai if they end up at Sinai, or Christ Hospital. And then to your question about how folks enroll, I mean, one point of entry is the hospital. We have community-based programs that are ideally engaging folks before they get to that point. Our best case scenario is that you don't get hurt. And we engage whatever creative methods we can to help folks get out of a lifestyle in which they might get hurt into a lifestyle in which they are less likely to get hurt. So that includes addressing any of their employment needs, education needs, re-engaging in school is something we do. And then also we work with folks to make sure that they have health insurance and make sure that they have mental health care if that's something that's an issue for them. But we really focus on meeting folks where they're at. So we will take anybody into our program in terms of engaging with them and working with them. So that's a patient or a family. In the case of someone who's working at the hospital, in our community-based sites, we're targeting the highest risk, but we'll work with folks that are around the highest risk in terms of supporting their entire situation to improve. So our service to the hospital is really pretty straightforward. We want to make sure their patients have better outcomes. We've been able to demonstrate that through research that we're able to reduce folks from coming back with another injury. So that's a big point of our program, is to reduce the re-injuries associated with getting shot one time. And then of course we're trying to help them stay engaged with medical care if they're a patient, and that means making it to their follow-up appointments, for example, and making sure they find out if they have health insurance, if so, who's your primary care provider and where are you supposed to be getting your primary care services, so that you don't use the ER as your primary care if you don't know. So that's just sort of an example.
Excuse me,
Yeah.
for those of us who came in late, could you say what your programs are, each of the three of you, and then the names of your programs?
Sure, so it's on standing still. I work with Ceasefire, and we have partnerships with Mount Sinai, Stroger Hospital, Northwestern, and Christ Hospital to serve patients who are violently injured and their families, prevent retaliation and re-injury with those patients.
Thanks.
There was a question for you over here.
I got you.
Hey everyone, I had a quick question. So, I'm trying to figure out how to word it. So, you know how y'all help us with our services. Are there people to help us that are constituents or that look like us as well? Like, as your staff? You know what I'm saying? And if not, are y'all planning on hiring people from that community and stuff like that?
Right, so Ceasefire, so when we work in a community, for example, and we have some support staff in Woodlawn. We don't have an actual office in Woodlawn, but our staff who does violence interruption in Woodlawn is from Woodlawn. And the sites, I mean, that's the model itself, is you don't hire outside folks to fix what's going on in a community. You engage the folks typically that are already doing some of this work, just not getting paid for it or recognized for it, in terms of mediations or being that go-to person when people do have issues and want to work them out without violence. Those are the people we recruit, and they go through a paneling process so that folks at the community level are comfortable with them. We have police officers on our panels so we can ensure that they're not engaged in a lifestyle that puts them at risk. But that's the whole model with Ceasefire, is engaging folks from those neighborhoods to mediate conflicts and resolve those issues in their neighborhood. So it's not, I'm not from those neighborhoods and I'm not the one doing the response. So, I mean, I represent sort of the administrative and data side of the program, but even, I mean, speaking from my experience at Mount Sinai, I knew there were things I could not do for my patients, and there were problems. I mean, I didn't even know how to have a conversation with some of them at times. And so that's why engaging with Ceasefire, when I would ask a patient if they want a referral from Ceasefire, 9 times out of 10, they could tell me the location of a Ceasefire site in their community and or name a person that they knew that worked for Ceasefire. And they always wanted that referral. They knew that that was someone who was like them, who was there to help them. They trusted them already. So that's the Ceasefire model.
Oh, you're right. I want something, because there was nothing like this 30 years ago. You just take them to the hospital and just see them on the news. This is great, and you know, I love it, and I'm speaking for my mother and myself as prevention. Yeah, I want to thank everybody here, but this is great, and I know it's going to finally go somewhere, and I just wanted to say that for my mother. Great job, all you nurses and everybody out here that's fighting the senior citizens, the young people. Sensational.
Thank you. And so, on that amazing note, thank you so much for standing up and sharing that with us. We are going to get to the breakout part.
Coffee or something?
Okay. Now, everyone's attention, please. We're going to get back started now. Can I have everyone's attention? Thank you. So I hope everybody had a very fruitful conversation in the individual breakouts. At this time, we are going to report back what we talked about in our group. I only need 3 groups. Everybody make sure that at the end of the day, your butcher paper is up front, right? So just need 3 groups. So one person from that group to paraphrase, basically, what you wrote down on your butcher paper. Give us the very much so hearty meat of it. As we stated before, there are University of Chicago reps in the room. Everything that is on this paper eventually will go back to the Trauma Care Coaltion, and which then you can trust will go back to the University of Chicago. And so I want to volunteer my group, but don't see the person without butcher paper. So if I could get someone else to go first, and then someone to volunteer second right now. So who wants to go first? Who wants to go second? So this group first. Okay, and then hopefully my group will go last. So why don't we start with this group?
First question we addressed was what kind of services for the UFC Trauma Care Center should there be? We raised the question that came from the panel, aftercare, and pay attention to the length of time that aftercare. The experience from this group was that aftercare was shortened sometime. It was not significant enough, so it should lengthen it. Emphasis on violence interrupters is the kind of services that we'd like to see. Proceeding to the next question, what ways can University of Chicago improve its relationship? This might not seem like it's traditional, but establish a community center, like the CETA program, and summer jobs for children. That's why I'm saying it might not be a traditional emergency room, but do that. Train the doctors so the doctors are considered to be a part of the community, so that they see the problem from start to finish, especially in prevention. Establish relationship with the community so that the community can volunteer in the trauma center, so that they can become a resource for the trauma center. Establish a CPR class so that people can have in the community as volunteers the skills to help their families and emergency care before they go to the trauma center. Sustainable and continued funding for the trauma center to make sure that we don't go, it stops. okay? Build a relationship through continued festivals. There was an accusation that they don't come past 61st Street. At one time, there were festivals in the Midway. Okay, continue sponsor those festivals. Establish satellite clinics. Okay, there is a vacancy right now on 63rd and Cottage Grove that you could build a satellite clinic that is in the midst of the community that where most of the trauma patients may come from. Go down on parking. Okay, it can be build another parking lot and make parking for free. And the next question was, what kind of medical care should the University of Chicago focus on? Prenatal care, another question for prevention. Trauma care, of course, you have to put that in because that's what this is about. Of course, the continued research that it's doing, and primary care. Cut down on the cost of ambulance transports. That's expensive to the community. Decrease the waiting time in the emergency room. We don't want that to become a problem in the trauma center. And we also, and the cause of that wait time in the emergency room, we identified it as the technology, which must x-rays, we have to make x-rays faster, and we have to make blood work faster. Cut down on the waste and have zero tolerance for inefficiency. Some people notice who have been in the emergency room at the University of Chicago that sometimes the behavior may not be professional. And that's the perceptions of people that are in the emergency room. The next question, what kind of obstacles do we see that would help make the trauma center successful? Policing. Train police who do not harass people who are using the services, okay? We also realize that the question of retaliation is important, so police have to be there. So we want to make sure ceasefire is there, or violence interrupters are there that are trained to de-escalate. And the police officers from the University of Chicago Police Department, from the Chicago Police Department, have to be trained in de-escalation. And I'll put in there that they have to be evaluated for the stresses in their own life, so that they don't bring those stresses to work and blame the patients. And that's it. Oh, and importantly, incorporate the community and rely on the community as a resource. Okay?
Okay, so our next group, not to rush nobody, very quickly. Let's hear it. We're going to go just up here.
Okay. Well, University of Chicago actually had something that I never thought I'd do. To begin with, we need to first look at this. We need to separate the University of Chicago Hospital from the University of Chicago. And the reason for that, and that is a trauma center is based on medical and not the psychological training or teaching or other elements of the university itself as a historical learning factor. We invite the university to come, and we understand, especially I, being a retired paramedic, realize what trauma entails. One of the things that we believe is necessary, and that is that patients be educated as to why their wait has been prolonged. Okay, we need to actually train the community to understand how to be effective in learning themselves. Okay, there we go. Okay. One of the many concerns was the traffic and the possible noise from ambulances and that nice little helicopter that you all have sitting over here. We understand that a lot of people in the community have a problem with insurance. Understanding that from ambulance to recovery could go into the millions. A lot of that is in recoup. So maybe to educate or come up with solutions to basically deal with that.
All right, all right.
We talked about everything under the sun as well, but I cannot read William's handwriting.
I'm sorry.
We have a small addition.
Oh, please.
Okay. Well, helping the youth that's in the community, making them more involved in the services. Helping the youth that's in the community, helping them to become more involved in the services, preparing jobs for them, opening up additional services for them. Also, the aftercare, calling the patients, making sure that the patients feel like they're more than just a patient, making me feel like, this is the place that I would want to go to or recommend, making sure that the radius is a good radius, like you guys make sure, I don't want to say the radius, like it's a 5-mile radius, making sure that the trauma, serves the community and making sure that our taxes doesn't go up because of that.
Yeah, so I'll just add 3 brief things to what people have said. We talked about just a really general need amidst all of the detailed things that we've talked about to just have a well-staffed hospital so that things like interactions, things like random requests that patients have can be handled and nurses and doctors don't have to always run off and go somewhere else. And that's just like a basic question of ratios that gets negotiated with, for instance, the nurses union. Second, we talked about the hope that we all have for more meetings like this, and in particular for that to keep happening closer to the hospital and closer to ways that we want the hospital to institutionalize things like this. So we would like to have an advisory board that represents young people, people of all colors and neighborhoods, and we want the advisory board to host things like this and to host them in closer connection to university staff. We had university staff here today, but they weren't featured. And then finally, we talked about power and how we can continue to come up with ideas and then make them happen when some people do not think our ideas are important enough. And we asked the question, is it worth continuing to do the direct action that got us here? Maybe we've got what we need and don't want to upset the apple cart anymore. But we said that direct action has never been popular and will always probably continue to be useful, and that we do not have to only give our special treatment to the university. There are many other healthcare players on higher levels around insurance, and we can help to bring everyone together for this. So
very quickly, I'm going to let some folks add just a few things that weren't mentioned.
Our group had some specific questions. How involved is Dean Polanski? I spoke with Ms. Thomas about the plans being put together. It seems like at this time no plans have been put together, which is sort of good. We can help, direct how the plans are going. One of the main things we're talking about is how to stop violence in the community, which would also prevent there being future trauma patients, if he could sort of reach out in that manner to the community. And then also PTSD outreach to be given to relatives and family members, friends that come to the hospital to visit trauma victims. So that could also help additional stuff from not happening if someone is addressing the people that are involved with what happened. Well, a big concern too was high quality staffing. Will we have doctors helping, or are these going to be, nurse practitioners or not? Reaching out to schools, the students before they become, trauma victims. And most importantly, will groups like Ceasefire and Stop be allowed to be on these advisory councils that we're speaking about? Are we going to be actually involved? So, like I said before, it's sort of good there's no plans now, but we do need to be included in the plans. If we could speak to Dean Polanski on this, that would be wonderful. Thank you for being out tonight, Ms. Thompson.
All right.
So I really really just want to wrap us up with reminding us about what we move forward with, right? So one, making sure that every single butcher paper, whether you read something off of it or not, is up at the front so that the coalition can take that back, record that, and properly find a way to translate that to the University of Chicago and our meetings. But also to be mindful of something that I heard come up at a multitude of times, right? An advisory board. This is something that is real. This is something that will happen. And this is something that the community absolutely needs to be a part of, to be aware of, and also have say-so of. And so we want folks to always be mindful that STOP, as far as we know, isn't going anywhere. The Trauma Center Coalition, COCO, JCUA, these organizations are still very much so committed to the Trauma Center campaign as they were in 2010, last year, and to this very day. And so we're going to continue to do the type of organizing that we've been doing, to build the type of power that we've built, to bring the University of Chicago to where it is now and to push it to where it needs to be so that our communities can continue to not only exist, but actually survive and live, right? And so that it's specifically black people and young black people who are queer, who are trans, who are here and who are not being identified as people who need to be reached out and touched, are able to have that space made for them. So with that, I just want to say thank you to everybody that is here for being here, but also for being here over the years. And thank you to the different coalition members who helped put this together. I feel like I see a few hands. What's up?
Advisory board, I don't want it to just be an advisory board that people just say ideas and thoughts and it never gets heard. I would like to have a CEO, a president, a vice president, an executive, a director, somebody that 3 out of 5 of these ideas have to get administrated, you know, and it has to be thought out and put in, because there is no sense in having an advisory board of the community and nobody is doing anything. You know what I'm saying? That's a waste of my time, that's a waste of every single body's time that's here. So put a plan into action with this and show me that you're gonna have somebody on there that can make some decisions that can take it back. Thank you.
And on that note, good night. Thank y'all for coming. Appreciate and love y'all.